Let me just talk about the work we've been doing at the fund, personal interest of mine, lessons that we can draw from high-performing healthcare organisations and, of course, systems, given the emphasis now within the NHS on STPs, accountable care systems, integrated care systems, and the more integrated care partnerships we're seeing in Salford and elsewhere. Back in 2014, I wrote and the King's Fund published this report called, as you can see, Reforming the NHS from Within. And it was a fairly high-level review of what does the evidence tell us. If you look at different strategies for trying to improve and reform the NHS, what's worked, what hasn't worked. And equally interesting, what hasn't been tried that we should give more emphasis to. I know David wants to refer to this also in his presentation, so this will be some reinforcement of one of the key messages from today. So these are the questions that animated the work that I did leading up to that report. The focus on the English NHS, looking at the evidence that others have gathered, looking at the lessons and the implications. This report, as with all of the King's Fund's reports, you can read online, access freely, download from our website if you want to read more. And what we found in this work was, of course, the main emphasis in the recent past in England has been using these external methods and interventions. Targets and terror, targets and performance management continue to be important. Inspection, regulation, the Care Quality Commission and others. Going back to the internal market in the late 80s and early 90s, competition and choice, also favoured by the Blair government under Alan Milburn when he was the Health Secretary, and continued by Andrew Lansley up until the 2012 Health and Social Care Act. And not forgetting that huge increase in spending and investment between 2000 and 2010. And of course, many of these used together rather than separately, making it quite difficult for researchers then to say what was the impact of one or indeed the other. And the bottom line from our work, I do need to tell you this, by the way, is if the fire alarm goes off, there's no need to evacuate at 10:30. That didn't happen. Good job I read that. My refresher training program. Thank you, Neil. So, what's been the impact? Well, broadly speaking, quite modest, and certainly hasn't fulfilled the expectations of the believers in choice, competition, and so on. We know that targets have contributed to improvements in access alongside more money and service redesign, but targets have negative consequences too. Sometimes organisations misreport or partially report, and targets distort because they focus attention on areas like 4 hours, 18 weeks and cancer rates, perhaps at the expense of other areas of care which would have had higher priority if those targets had not existed. We know that CQC continues to be a very important part of the landscape, and that trusts in particular look forward to CQC visits and inspections, and it takes up a huge amount of time and effort in responding. What's been the impact? Well, the evaluations again show that it's been quite modest, and CQC inspections have negative consequences in the same way that targets do around the time and the effort that goes into preparing for and responding. Undoubtedly there's an impact. The question is the relationship between the positive outcomes and the effort that goes into that work, and the cost and the expense. And there are still true believers in competition and choice who would argue there have been measurable benefits. I'm sceptical of that. It depends how you interpret the different studies that have looked at competition, the impact on outcomes, for example. It feels to me that the evidence is limited and contested, and doesn't give anybody real confidence to say that competition in the context of a publicly funded health service like the NHS, will deliver beneficial results at scale. So what hasn't been tried? What can we learn by looking outside England at other healthcare systems? Well, I'm going to talk mainly about the first of these, reform from within, but also want to recognise the role of devolution and transparency, if you like, collecting and reporting performance data, whether that's about outcomes or efficiency or patient satisfaction, making that transparent and believing that that will help to improve performance. If you like, you're embarrassing organisations that don't perform well by making visible how they're doing in comparison with others. Not new, and this has been tried from time to time within the NHS, but it hasn't been as salient as the other mechanisms I've mentioned so far. Here are the logos of some of the organisations we've looked at that stand out as being high-performing organisations, or in some cases, high-performing systems. And of course, one of these very close to where we are today. We selected these on the basis of them being recognised as high-performing. They have the data to show they deliver good results in relation to the resources that are available to them, using a variety of different metrics for that purpose. They are case studies only. There are other pieces of work which underpin what I'm about to say, so please look at the full report for more detail. And what we conclude from this work is that there should be less reliance on these external stimuli, much more focus on bringing about improvement from within, focus on, if you like, commitment to improvement rather than compliance with somebody else's targets and somebody else's standards. And that complementary changes should be used. I'll illustrate that in a moment through talking about one of the case studies. It's not either or, it's both and when it comes to reform strategies. What we can learn looking across these organisations are a number of key points. All of them set ambitious, measurable goals for improvement. It can be about saving lives, it can be about improving patient experience, it can be about delivering greater efficiency. That's the first building block. You also then need to measure whether you're making progress in delivering on those goals, and do that relentlessly and make that information available. A lot of the work that's been done is about supporting clinical teams, managers working with clinical teams to acquire the skills and the expertise, and that's about training and development, and we've heard about some of that already this morning. It's about staff engagement, and it's about, if you like, the microsystems, the basic building blocks, the teams that deliver care to patients, who, taken together, make up these organisations and systems, because change happens at the level of teams as well as the level of organisations. And that requires leadership not just in the boardroom, not just in the executive suite, distributed and collective across organisations and systems. So when I was doing this work, I spent some time with David Dalton and his colleagues at Salford Royal. And it's a much more interesting and longer and more complex story, but part of it is a point in their quality improvement journey, setting a goal, this bold goal about becoming the safest hospital in England, inspired in part by the work of the IHI in Boston, and setting this measurable goal of saving 1,000 lives and reducing harm by 50% in 3 years. How to deliver that? Well, supporting staff through training in quality improvement methods like PDSA cycles, again drawing on the experience of organisations like the IHI, investing in medical and other clinical leaders, improving bottom up through these microsystems and the teams in the microsystems and by staff involvement. I talked to David Dalton about this work, and my cheeky question to him was, so you've emphasised this is bottom up, so was there a social movement in Salford Royal where the staff came to you, David, and said, we want to become the safest hospital in England? And of course he said no, That didn't happen. That ambitious goal emerged among the top leaders of the organisation, and David and his colleagues who reflected on what they did want to achieve. But the delivery of that came bottom up through teams, through the executives supporting those teams, getting alongside them, devolving as much as possible in a belief, looking at experience elsewhere, that will be a very effective way of working towards this goal. So that's what I mean by talking about complementary changes. You need organisational leadership, but you need this collective and distributed leadership. Both are important. We know that real improvement takes time. It occurs, if you want to use the phrase, I think, from David Brailsford in relation to cycling and the achievements of the British cycling team in the Olympics. It's about the aggregation of marginal gains. Lots of small changes together add up to improvement, not one big leap forward. And NHS organisations therefore have to build and invest in building the capabilities over the long term. The Veterans Health Administration, the VA for short, is another case study of a high-performing healthcare system, and we've worked closely with them and Ken Kaiser, who was their leader during that transformation. Essentially, it took 5 years, which actually is quite a short period of time, to move from being an organisation, a healthcare system on the brink of failure, on the brink of being closed down by the US government because it's a public agency, to being seen as an exemplar. A 5-year transformation turnaround, so the VA at the end of that period was looked up to as a system that public and private healthcare organisations in the US wanted to emulate because of the improvements that had occurred. Another example of complementary changes, top-level leadership, devolution to accountable care systems, as we would call them, and devolution within those systems to frontline teams in the way I've been describing. So let me just bring this to a close. This requires boards, NHS trust boards in particular, to do the things I've mentioned here. Another example from close to home, Sheffield. We were due to have Susie Bailey, who worked with Tom Downs and others in Sheffield, with us today, but she's been snowed in her home. I'm sure she would have talked about the work that Sheffield Teaching Hospitals Trust has done, developing its own QI method, adapting from IHI, and living these sorts of values that we can distill from experience. CQC in 2014 said this. I'm not going to read it out. Let me just leave that for you to have a look at and you can read yourselves. I think that's a very powerful encapsulation of the leadership role in quality improvement. And finally, the work that we've done at the Fund, led by my colleague Michael West and others, which describes in more detail what it means to develop collective leadership for healthcare at all levels, managers working with clinicians from board to ward, a theme I'm sure we'll come back to during the course of the day.